Hi, everyone. Good afternoon. I'm Stephanie Cooper Greenberg. Dr. David McConkey is with us too on this uh, fantastic afternoon where we're going to be talking about upper tract urothelial cancer. We call it UTUC around here. And the topic of today is UTUC, and it's having quite a moment in medicine and in it's having its own renaissance or its own recognition. And for many of you, those of you tuning in, I'm sure you would appreciate that. It's not bladder cancer and it's not kidney cancer, it's its own cancer. And there's no one better to help explain what the progress and updates are in treating and understanding UTUC than our own Dr. Nirmish Singla, who is an assistant professor of urology and oncology here at the Brady Urological Institute, who will be our fantastic speaker today. So, first of all, we welcome everyone. We want to just do some housekeeping here. If you have any questions or inquiries about bladder cancer or more specifically the upper tract urothelial cancer program, we have two dedicated email addresses for inquiries. It's a lot quicker than sort of trying to find it on your own. So, number one, if you Google our website, Greenberg Bladder Cancer Institute, you will find that we have two email addresses for any questions, anything you want to ask us, um, uh, specific, not specific, a question you forgot to ask in today's program, you'll get an answer. They are monitored. The first one is simple, bladder cancer at jhmi.edu. That stands for Johns Hopkins Medical Institutions.edu. It's a mouthful. And the second email address pertinent to today's talk is called UTUC, full caps, at jhmi.edu. We also want to share with you that we have a thriving women's bladder cancer program that also includes patients with UTUC for women only, based out of Sibley Memorial Hospital in Washington, led by our fantastic Dr. Armin Smith and Jeannie Hoffman Census. And they have their own speaker series. The next one session coming up will be on May 7th, all free, all are welcome, as long as you're a woman, from 4 to 5. And this one will be on improving quality of life and what palliative care really means. It's often misnamed. But that aside, this program today is specific to upper tract urothelial cancer. And I'm incredibly grateful to have Dr. Nirmish Singla speak to us on this topic. And it's a specialty of his, along with faculty member Jeannie Hoffman Census, who is a medical oncologist. They work together and they have a clinic together. And you will hear from Nirmish on what is up and coming in UTUC. Before I do that, on our website, you'll also find two handy pieces of information. We created what's called a question checklist. So this is a downloadable PDF of questions that you as patients should or could or maybe want to ask your provider anywhere you are, whether at Hopkins or otherwise. When we know what it's like, you go to the doctor and you can't remember anything and you're totally paralyzed and your mind goes blank and you wanted to ask all these questions about treatments or care or how long is this going to take and can I still go to work and what resources do you have available, stuff like that. Really important, but we often get in the moment and can't remember what we wanted to ask. So this is a handy question checklist to download, print out, and bring with you, or just simply have on your phone. The questions are there for you to use, and maybe they can be helpful. And in addition, we also have a provider. Hopkins is a big place with many, many different locations. And we also have a provider checklist of names, addresses, phone numbers, like where you go for what, where, and when. And that's also on our website. So those are just handy tools that we created for you. Dr. Nirmish Singla is an associate professor of urology and oncology at the Brady Urological Institute at Johns Hopkins. He serves as the director of translational research in genitory oncology, and he helps lead the multidisciplinary kidney cancer program at Hopkins and is co-leader of the Upper Tract program, which you will hear about today. He attended the University of Michigan Medical School and completed his residency in urologic training as a surgeon at the University of Texas Southwestern Medical Center. He then completed a specialized clinical fellowship in urologic oncology at Memorial Sloan Kettering in New York City, and has joined us as an associate professor on our faculty, and we couldn't be more delighted or thrilled to have him with us. He's going to give a brief talk today with slides explaining UTUC. So if you have any questions, please stick them in the chat. We're going to answer them. And David and I will be on hand to ask your question for you. And so please just fire away. And this is your moment to ask great questions of Dr. Singla. So with that, thank you all for coming. And we're going to have a great session today on UTUC having its moment. So here we go. Dr. Singla, you are famous in UTUC world, and welcome and thank you for joining us today. Now, before we start your nifty slides, and they are nifty, I had a question for you. You went to the University of Michigan and you're a very accomplished surgeon and you're genitourinary, blah, blah, blah. But I really want to know your story. How did you happen to come to be an expert in UTUC, which, by the way, I looked it up. It's between, they say it's 6,000 to 7,000 cases in the United States per year, which would qualify it as sort of a rare disease, I would say, or maybe it's misdiagnosed. But how did you happen to did you find UTUC or did it find you? And tell us your story of how you chose this field of expertise, because arguably you and Jeannie are among the leaders in this field and recognizing UTUC as its own separate disease state. So we'd really like to hear how you came, how we have you today, and how this happened.
Yeah, absolutely. And first and foremost, thank you so much, Stephanie and Dr. McConkey, and special thanks to the GBCI at large for this opportunity to talk about UTUC. It's really my honor and privilege to be able to talk about it. And I think for those who have heard this talk before, I think many would find this to be maybe highlighting some points that I think are easily forgotten. But to your question, Stephanie, as you mentioned, UTUC is such an uncommon and a rare disease, certainly in the U.S. and also certainly globally. And I think to sort of answer how did I come across it, or was it me that found UTUC or vice versa? I think to be honest, in large part, I probably owe it to my own training and the exposure I had gotten from other experts in the field that now have become colleagues. Examples would include Dr. Vitaly Margulis at UT Southwestern, Dr. Jonathan Coleman at Memorial Sloan Kettering. And I think throughout my own training, just both clinically seeing patients with UTUC and learning about how complex their multidisciplinary care is, the close association that we as surgeons must have with our medical oncology team, and the cognitive aspects of managing this disease really attracted me. Not to mention that, when I had started my training, I would say that in large part, UTUC wasn't really as well recognized as its own entity. In my own training, I would say residency for me started in 2013, so just barely over 10 years ago. And I will say that within just the past decade alone, there has been so much that has emerged within the field of UTUC that we'll go over today. And being part of that throughout my training and now in the last 5 years as faculty here, and really recognizing it as its own entity has really made me even more interested, honestly, in studying this disease and kind of bridging bladder cancer and kidney cancer in a way that's very unique. With its own set of nuances. And that's how I think I became very interested in it, both clinically and academically.
Great. Thank you. Well, we're delighted and thrilled. But your initial study, was it bladder cancer first? Or I know you're a world expert in kidney cancer as well, or in all of them, but is that where did you choose kidney as well? I mean, you're sort of in the general real estate area.
Yeah. I guess you could say it's a similar real estate, maybe differing biologies, but I think that Certainly kidney cancer, upper tract urothelial cancer, surgically, there are a lot of similarities. To me, they're just really fun operations to do when managing patients, but
Dr.
even
Singla, nenever say it's a really fun operation to do. No, no.
fair, that's fair. But cognitively, they are definitely very stimulating, and I think that for me, having that exposure throughout training and continuing to sort of live in an academic community where you're constantly challenged to sort of push the needle forward, whether it be in kidney cancer or in the space of urothelial cancer, and more specifically in UTUC, I think those are really what keep me engaged.
Well, I'll say this, if for our patients who have UTUC, our dream, we feel that every person affected by bladder cancer, kidney cancer, UTUC especially, have a home to where they can come and be treated. I feel in my heart that that's kind of the whole purpose of this. And to have UTUC and have it be sort of unrecognized, which I'm sure you'll talk about, or misdiagnosed, which I'm sure you'll talk about, or not really recognized as its own entity must be, sort of almost painful. But I think the good news that from your talk, which I will let you give, is that times have changed and that we recognize, we hear you, we see you, and I'm sure um, what a relief it is to be sort of have the knowledge to say this is not that and it's not that, it's UTUC. So with that, I can't thank you enough, and we're super glad that maybe UTUC did in fact find you, and that you have your knowledge and your expertise to share with our patients. So um, I think I'll let you go with your slides, and then again, please everyone answer your questions in the chat, and we'll be right here to articulate them for you.
Terrific. Well, thank you again, Stephanie, for your kind words, and I appreciate this platform. So, without further ado, I think you gave a really nice prelude to what I'm planning to discuss today. But as you mentioned, UTUC, it truly is its own entity, and I think, like I mentioned, in the last decade alone, there's been so much that we've learned about this disease on a clinical level, on a biological level, that continues to offer support to this concept that it's not bladder cancer exactly, and it's not kidney cancer certainly, but rather it's its own entity and it deserves its own attention as such. Um, so, just to begin, there are some just industry-sponsored disclosures, and also a special shout out also to Joe Migliara for funding some of the work that will be presented here as well, who is himself a Brady board member. So just to start off, again, like Stephanie said, UTUC, it is its own kind of entity, and that it also includes, just in terms of where it's found in the body. When it comes to UTUC, it's the type of cancer that arises from the urothelial lining of the urinary tract, but from the upper urinary tract. So rather than kidney cancer, which comes from essentially the outer meat of the kidney, if you will, UTUC arises from the inner lining of the kidney, where the urine typically collects, also known as the renal pelvis or the calyces of the kidney, or it can also arise from the ureter, which is the tube that drains the urine from the kidney down to the bladder. It's the same type of lining that coats the bladder, and hence the word urothelial, or urothelium, is derived. But essentially, while 90 to 95% of all urothelial cancers arise from the lower urinary tract or are bladder cancers, only about 5 to 10% of these types of cancers arise from the ureter or the renal pelvis and are thus classified as upper tract urothelial carcinoma. There are many challenges when it comes to understanding and managing this disease. First, it's important to recognize that, again, it's a relatively rare population and oftentimes can be challenging to diagnose. Many times these patients are often asymptomatic, or they may be detected because of the presence of either microhematuria, or in other words, some blood that's found microscopically within the urine. Occasionally, there can be some associated flank pain, but that's oftentimes not the case. Or oftentimes it may just simply be that it's incidentally detected on imaging that may have been acquired for unrelated reasons. And so, even in that setting, sometimes the imaging findings can themselves be quite subtle, and so it really amounts to the possibility of being delayed in terms of actually catching this disease. There are some unique risk factors associated with UTUC as well. Most commonly, there's tobacco exposure, which is an overlapping risk factor with bladder cancer as we know it. But in addition, aside from what we know about bladder cancer, there are also unique aspects related to UTUC pathogenesis. There is a hereditary syndrome called Lynch syndrome or hereditary non-polyposis polyposis colorectal cancer that uniquely tends to be associated with UTUC more so than it is with bladder cancer. And then in other parts of the world, we tend to sometimes see an association of UTUC with a risk factor known as aristolochic acid. This is actually an ingredient that is often found in traditional Chinese herbal medications, but also in endemic to certain parts of the world, specifically in the Balkans region. And so, whereas this isn't more often seen in the US compared to other places, it is a unique nephrotoxic carcinogen that has been associated very uniquely with UTUC and not, for example, bladder cancer or kidney cancer for that matter. I mentioned that diagnosis can be challenging, and part of the issue also is in comparison to bladder cancer, where you have larger instruments to work with and can acquire larger samples or sometimes the entirety of a tumor in the bladder. We're often more limited to the use of ureteroscopes, which have much smaller diameters and much smaller working channels to actually even get samples of tumor tissue in the ureter and the kidney. And so oftentimes we're working with very scant samples, sometimes just even a few millimeters across at best, that we're working with in order to actually make this diagnosis. And there can be oftentimes, they can often be subject to undergrading or undersampling issues, which I'll mention in a bit to a greater extent. And furthermore, oftentimes these can be very challenging to stage clinically based on imaging, which is the gold standard of which is typically to get cross-sectional scans with a CT. But understanding the depth of invasion for these types of tumors can be very challenging to ascertain on scans. And likewise, you're often not able to get very deep bites with a biopsy in terms of understanding the depth of invasion. What's unique also about UTUC is that oftentimes there is potentially a need to remove a kidney from the body. And as a result, in comparison to bladder cancer, where sometimes the need to remove a bladder may not have as dramatic of an effect on kidney function can play a very important role in these patients. And likewise, we're continuing to learn more about the role for giving systemic therapy either before and or after surgery. We have modest, I would say, at best, prospective data before surgery or in the neoadjuvant setting, and maybe better data in the adjuvant setting, but the ability to give chemotherapy sometimes can be limited by kidney function or other comorbidities afterwards. And so these are all important considerations that I would say are unique to UTUC. And so, as a clinician, when it comes to sort of the question of how do you really approach a patient with UTUC, it really boils down to a risk-based approach of management. And that's often driven by what we ascertain for grade based on these biopsy samples, as well as our overall gestalt of clinical stage, i.e., do we think that a patient is metastatic or has it spread to other places in the body, or simply localized or locally advanced, where it may be just more or less limited to the kidney. For all intents and purposes today, my goal will be to primarily focus on patients with non-metastatic upper tract urothelial cancer. As Stephanie alluded to, my partner in crime for this disease state is Dr. Jeannie Hoffman, since it's on the medical oncology side, and she tends to treat patients with more aggressive forms of this disease. But even within the localized setting, there are a lot of unique nuances, clinical trials, and integration between surgeons and medical oncologists that ought to happen for selected scenarios. And so I think that even in this setting alone, there's a lot to be discussed. So I've sort of broken up this talk into thinking about patients with low grade or low risk disease, and then alternatively those with higher grade or perhaps higher risk disease, because that really kind of directs what type of an approach one would use. So starting off with low grade UTUC. In this setting, the overall goal of management would be to really accurately grade patients, think about preservation of kidney function, and then also avoiding compromise of oncologic or cancer control. The good news is that low-grade disease generally tends to be the type that is non-invasive, so in other words, superficial, and generally one that we don't expect to have the capacity to metastasize or spread to other parts of the body. And so I tend to think about these types of tumors as um, more or less nuisance tumors, because even though these are tumors that don't tend to progress, they do tend to be the types of tumors that can sometimes recur and actually very frequently tend to recur anywhere along the urinary tract. So with the idea that we want to try to preserve kidney function in patients, we have found that oncologic control in low-grade disease can be achievable through kidney-sparing means or endoscopic means alone. And for many patients, removing a kidney and ureter may be considered overtreatment. One important caveat to note is that when it comes to these biopsies, again, I mentioned that undergrading is a common issue, and that's actually seen in up to even as high as 50% of the time, depending on the series you see. But some of the more contemporary multi-institutional series have reported that in patients who do undergo a nephroureterectomy, up to half of patients may have upgrading from low grade to high grade disease. And this may be attributed either to insufficient tumor sampling or heterogeneity within these tumors, where there may be certain parts of tumors that are lower grade compared to other parts. So that's why really trying to get a fair degree of confidence in our ability to grade these tumors is important to make sure we're not undertreating them. And then from there, figuring out the right balance of preserving kidney function while maintaining adequate control from a cancer perspective. In general, these are the tools in our toolkit for managing low-grade UTUC. There's kind of the classic surgical removal, which tends to be a little bit more radical. Sometimes it can entail removal of a kidney and a ureter, or just a portion of the ureter alone when feasible. Again, it may be necessary in some patients, whereas for others, it may be potentially overtreatment. Endoscopic ablation alone, this is a technique that involves using a laser fiber to try and kill these tumors, again, because we think that these tumors generally tend to behave in a non-invasive or superficial manner. And so either using a ureteroscope in a form that involves no incisions going from below, from the urethra into the bladder and up into the upper urinary tract, in other words, in a retrograde manner, trying to kill tumors with a laser, or antegrade, going from above and going into the kidney from the backside, and then trying to kill tumors using a laser, are equally acceptable. Sometimes, though, there can be challenges in terms of completely ablating tumors using this approach, and so we have another nifty trick, I would say, in our belts, that is something called primary chemoablation that I'll go over in just a bit. But that's essentially topical installation of a chemotherapy. And then there are other emerging techniques, including a clinical trial that we are also participating in, that I'll briefly touch on. So in terms of this primary chemoablation that I referred to, there's actually a phase 3 single arm trial. Hopkins was a participating site, referred to as the Olympus trial, that was published in 2020, that actually led to the FDA approval of this agent that involves a topical chemotherapy called mitomycin C that more historically had been very frequently used for topical management of patients with low-grade bladder cancer. That's actually suspended in what's called a reverse thermal hydrogel. And the reason why that's pertinent is because as one maybe can imagine, it's one thing in the bladder when you instill a chemotherapy agent, or let's say BCG, being an immunoagent, into the bladder. A patient has the ability to hold the agent in the bladder for a prolonged duration, and that allows for adequate contact time between the agent and the bladder wall. The problem with the upper urinary tract is that because of the effect of gravity, if you were to instill a liquid into the kidney, it almost immediately would go down and end up in the bladder. So the contact time ends up being pretty limited between the agent and the tumor, limiting its efficacy. So this compound, which is basically mitomycin C that's suspended in this reverse thermal hydrogel polymer, is designed such that it is basically suspended in a liquid when at colder temperatures, and then when it's introduced into the body at warmer temperatures, it converts to this semi-solid gel-like state that remains in that state for approximately 4 to 6 hours before re-liquefying. And that allows for that duration of time where the mitomycin C chemotherapy agent can be exposed to tumors before going down the urinary tract and into the bladder. In terms of the results from this initial trial that I mentioned, first and foremost, kudos to the investigative team, because this is the first time that the FDA actually approved any agent for low-grade UTUC, which in and of itself is such a unique niche space, a very uncommon space. And this was the first prospective study that reported the activity of a topical chemoablative treatment for low-grade UTUC. 59% of patients had demonstrated a complete response to induction therapy alone, which is essentially 6 cycles of this treatment. And then just hot off the press this month was a long-term durability study that was published in the Journal of Urology that revealed that among patients who had demonstrated an initial complete response, 75% of patients continued to have a durable response with no evidence of recurrence. And this was across the median follow-up of 53 months. So this was, I would say, relatively remarkable in terms of the response rates, especially because many of these patients can be challenging to manage endoscopically, or sometimes there may be small nidus of low-grade tumors that are not really seen the first time around, and maybe have an opportunity to grow and become noticeable on a subsequent ureteroscopy. But it is something worth noting that there is a high rate of ureteric stenosis that is reported with this treatment, actually as high as even 40 to 50%. And while it tends to be transient and self-limited in the majority of cases, it really is a clinically significant finding. And I can tell you anecdotally, there are a handful of patients who have had symptoms related to the development of ureteric stenosis, and that can become challenging for many to continue treatment. And so it is an important caveat that we're aware of when it comes to this agent. And there's ongoing investigation for other opportunities to instill various agents into the upper urinary tract using a similar paradigm of a reverse thermal hydrogel. But nevertheless, it is nice to have an FDA-approved kidney-sparing treatment alternative for these types of patients, especially for those with either multifocal disease or patients who are not great candidates for endoscopic ablation just simply due to volume alone. And like I mentioned, it is something that we offer at Johns Hopkins. We typically do an antegrade installation, which involves the insertion of a nephrostomy tube temporarily, through which the treatments would be administered simply in the clinic without the need for any anesthesia. So it tends to be actually quite convenient for patients.
Dr. Singla, it's Stephanie. I'm going to ask you,
Please.
can you define for me and for others maybe your stenosis? Please help
Yes.
us understand
I'm
exactly what.
sorry. Yes, by stenosis, I mean narrowing or obstruction. So if you think of it like the ureter like a straw, essentially there's what can develop internal to the ureter is this area where essentially, whether it's due to scarring or local inflammation, it essentially closes up in that region. And so it basically obstructs or prevents the flow of urine from the kidney down to the bladder,
Oh, wow.
which
So
can, as you
that's
can imagine,
pretty big. That's a pretty significant. And
exactly.
is there a way to fix that? Is it you put a stent in or?
So in general, most of the time they tend to be self-limited, meaning that it'll improve on its own. It is a dose-dependent effect. So as patients continue to receive more and more treatments, there becomes a bit of a higher risk of developing this stenosis or narrowing. There are opportunities in more significant scenarios to treat patients with steroids. We've found that sometimes steroids can help alleviate or accelerate the recovery from stenosis. But certainly inserting a stent is another option, just to simply bypass the obstruction. In patients who do have a nephrostomy tube in place, like I mentioned at Hopkins, we do the installation of this agent through a percutaneous nephrostomy tube. One of the nice things is a simple fix that even a patient can do at home, is especially if they have a bag where they can hook up to the nephrostomy, is simply just opening the cap of the nephrostomy as a pop-off valve, essentially, and that alleviates the obstruction of the kidney and helps protect the kidney if there is any obstruction that has developed in the ureter. And again, feel free to stop me at any time. I did want to talk a bit also, just because we're talking a bit about horizons, the future horizon of UTUC as well in this talk, and just forward looking beyond that which has already been done is where do we go from here? And another unique thing in the UTUC space, in the low grade disease space, is something that's being explored not just across the country, but actually with collaborators across the globe, including in Europe as well. And we're part of a phase 3 trial for something called TUCAD, or what's known as the Enlighted trial. And just to give a brief sort of introduction, what this is, there's an agent called ptyloporphin, which is administered intravenously. That's a photosensitizing agent. It tends to target the vascular compartment of the body, and these types of tumors tend to be hypervascular or have a lot of blood vessels. And so there may be a preferential uptake of this agent within the blood vessels of these tumors. And when activated at a very specific wavelength, 753 nanometers, um, it actually induces the ptyloporphin to release free radicals and cause necrosis or killing of the tumor by causing a vascular occlusion. And this has been a technique that has been studied in a variety of contexts, not just in UTUC, but specific to UTUC. Our colleagues at Memorial Sloan Kettering, led by Dr. Coleman, had a couple of years ago published a phase 1 results of using this agent in a limited set of patients, and found that it was actually quite demonstrated quite encouraging results with respect to local response rates within the primary tumors, for low-grade tumors especially. And prior to that, had also participated in a series of preclinical studies that likewise demonstrated encouraging activity. So we are currently still recruiting for this single-arm phase 3 international trial called the Enlighted study, where we're looking for patients with low-grade upper tract urothelial cancers. There are some strict guidelines in terms of tumor size and focality, but certainly we're very eager to see if similar to the way the Olympus study led to the approval for UGN 101 or Jelmyto for low-grade UTUC tumors, we're eager to see if this type of a strategy may be another alternative way of enhancing our ability to ablate tumors using this type of an agent. So I'd like to shift gears and talk more now about high-grade UTUC, because I think this one really involves more of a multidisciplinary discussion, and is a state for which we have, again, multiple clinical trials in action, including those led here at Hopkins. When it comes to managing high-grade UTUC, classically, the gold standard approach generally entails what we call extirpative surgery, or surgery to remove the primary tumor. In general, this typically entails what's called a radical nephroureterectomy. That involves removal of the kidney and the ureter all the way down to where it reaches the bladder. And that also entails the need to remove what's called a bladder cuff, or basically a little margin of tissue from the bladder around where the ureter inserts into it. There are also predefined templates of lymph node dissections that are advocated for based on where the location of the tumor is, either in the upper part of the ureter or in the kidney versus in the lower part of the ureter. And I put in a little picture here just to highlight some artwork that one of our own graduate students in the medical illustrations program here at Hopkins a couple of years ago had put together as part of his thesis. I was actually quite impressed with his work, but from observing one of these surgeries on one of my OR days, he had managed to put together this really nice illustration of what I mean when I say bladder cuff, and really kind of opening the bladder and removing that inner segment of ureter prior to closing up the hole in the bladder. Now, in selected scenarios, it is acceptable to do what's called a partial ureterectomy or a distal ureterectomy, where just the affected segment of ureter is removed. And that is something that there are some nuances associated with that. Number one is ensuring that oncologically there's no compromise in integrity. So that means negative surgical margins need to be acquired. There should be no further tumors higher up, certainly. Otherwise, it sort of defeats the purpose of doing this approach. But then furthermore, there's also kind of the challenging aspect of making sure the plumbing reaches each other. So if you're able to remove a segment of ureter and then reconnect the normal segment of ureter into the bladder again, then it makes sense. But if that becomes technically infeasible, then sometimes those are settings in which we simply have to remove the kidney and the ureter as well. But it is a technique that has been advocated for in selected scenarios as an opportunity to continue to preserve the kidney. And I will say that I do the majority of these surgeries robotically as in an effort to minimize the morbidity and expedite the recovery process after undergoing this type of surgery. And patients do actually quite well. I would say maybe on average about 2/3 or more of patients tend to go home even the day after surgery for something like this now with a robotic approach, which has been really helpful in terms of getting them back to baseline sooner rather than later. I had alluded to earlier as well that aside from just surgery alone, there has been growing evidence supporting the use of perioperative therapies. And this is where partnering with Dr. Hoffman Sensitz and other medical oncologists has been very helpful in terms of counseling patients and to go over some of the data, which I'll share with you shortly, regarding the role for either giving therapy prior to and or after surgery. And then lastly, I'll mention that there have been other approaches in efforts to preserve kidney function, or perhaps in patients who may not be the best candidate because of other medical issues to undergo a radical surgery, approaches that have entailed the use of endoscopic techniques like laser ablation alone, or topical treatments like the use of BCG, which has historically been used for bladder cancers, non-muscle invasive bladder cancers. These are alternative strategies, but I would just caution the use of this on a routine basis, just simply because there is a concern that the treatment may be inadequate by using these approaches for high-grade disease, simply because these often tend to be more invasive tumors, and we may be missing more than what meets the eye. And so these sometimes are more often reserved for palliative intent rather than for primary treatment in high-grade settings. Now, on to perioperative chemotherapy. I will mention that while in the sphere of muscle invasive bladder cancer, neoadjuvant chemotherapy has become the gold standard now for over 20 years, predicated on a prospective phase 3 randomized controlled trial. The data that it's not exactly a direct extrapolation to upper tract urothelial cancer, but we've investigated the same types of agents that are essentially cisplatin-based agents in the same setting of upper tract urothelial cancer. And to date, there have been two published prospective phase 2 trials for the use of neoadjuvant cisplatin-based chemotherapy before radical nephroureterectomy in UTUC, and one prospective phase 3 randomized controlled trial that emerged from the UK for the use of adjuvant cisplatin-based chemotherapy after nephroureterectomy in UTUC. Now, an important aspect of deciding when to give therapy is essentially kidney function and timing in relation to surgery, because again, timing is critical when it comes to eligibility for receipt of cisplatin-based chemotherapy. Even at baseline, before undergoing removal of a kidney unit or a renal unit, only 58% of patients or less may be eligible to receive neoadjuvant chemotherapy, and that may be due to either poor baseline kidney function or other medical issues that may that may complicate their ability to receive chemotherapy. And that's largely also because, honestly, cisplatin can be a very harsh chemotherapy agent. And so then it becomes a balance of side effects from chemotherapy versus the perceived benefit from a cancer perspective. Unfortunately, for patients who undergo a removal of their kidney or nephroureterectomy, postoperatively, their renal function may be further compromised to the point where the actual eligibility to receive cisplatin-based chemotherapy drops down to 15%. And that's why institutionally we have started to advocate more and more for giving it in the neoadjuvant setting, where more patients have the opportunity to derive benefits from chemotherapy compared to waiting until after surgery. When it comes to kind of a conceptual framework for thinking about the neoadjuvant and the adjuvant space, in terms of what we know, neoadjuvantly, one of the nice things is that we've seen a pathologic complete response, so meaning complete killing of the primary tumor in anywhere from 14 to 19% of cases. It's a bit It's about half of what we see in the setting of for bladder cancer in patients who are undergoing neoadjuvant chemotherapy before cystectomy, but it's still, I would say, not insubstantial by any means. And even furthermore, I would say that from these trials, we have found that about 60% of patients have a non-invasive or a T1 or less stage at the time of surgery. And this may be due to either downstaging or inherently being lower stage to begin with, again, due to the limitations of clinical staging. The thought of giving it neoadjuvantly is that it gives us the opportunity to maximize candidacy to receive the chemotherapy with both kidneys in place. But on the flip side, the counter argument is that there may be a subset of patients that may not even need chemotherapy if they are inherently lower stage to begin with. As I mentioned, it tends to be our institutional preference in appropriate candidates to give it upfront before surgery. And I will just give a shout out to Dr. Hoffman since she is the global PI on a national phase 3 randomized controlled trial of investigating the use of immunotherapy in conjunction with chemotherapy before surgery. So looking at basically chemotherapy alone versus chemotherapy plus durvalumab, which is an immune checkpoint inhibitor prior to surgery. And so we are eager to see how the effects of immunotherapy can enhance the role for chemotherapy in patients with UTUC. In terms of the adjuvant data, as I had mentioned, there was a phase 3 randomized controlled trial that came out of the United Kingdom where they had compared patients who had undergone surgery followed by observation alone versus surgery plus adjuvant receipt of cisplatin-based chemotherapy. And they did find that in patients with primarily patients with more aggressive disease pathology at the time of surgery, both recurrence-free as well as overall survival were improved with the receipt of chemotherapy. And so it is guideline advocated that at least for patients who did not receive chemotherapy before surgery, it should certainly be offered in patients who have more aggressive disease. And I don't have a slide on this, but I will also mention that based on some data that was published last year across all urothelial cancers in patients who had received neoadjuvant chemotherapy and still have residual disease, residual aggressive disease at the time of surgery, there is also an option to administer immunotherapy after surgery. And so it gives us another option in patients that maybe have compromised kidney function after undergoing a nephroureterectomy, whether or not they had received chemotherapy upfront. I do want to give another shout out to Dr. Hoffman Census because this is kind of the newest development here at Hopkins and another clinical trial for which we are actively accruing. This is more or less her brainchild, but it sort of highlights how we have really tremendously benefited from having a multidisciplinary environment where we can work very closely with our medical oncology team here. But there's been a lot of interest from patients, certainly, and from providers in finding out whether there are ways we can even avoid surgery altogether in patients who have high-grade UTUC. And so this so-called renal retention trial was developed as a relatively early phase trial, just looking to accrue 20 patients for this pilot trial in patients who are either ineligible for or refuse radical nephroureterectomy. And essentially, we now have this unique. I would consider it like a wonder drug regimen, but there's a drug called enfortumab vedotin that now, in conjunction with an immunotherapy called pembrolizumab or Keytruda, is the brand name. Pembrolizumab and enfortumab vedotin have moved to a first-line role, a first-line standard of care for patients with metastatic disease. But we're also starting to find that, at least off trial, in patients who are ineligible to undergo surgery or are considered surgically unresectable or medically unresectable because of other disease-related characteristics, we're actually starting to find that there's some unique activity of this drug combination within the primary tumor where we believe there may be an opportunity to actually completely even treat tumors without undergoing surgery. And so the role of this trial is to see whether this is a feasible regimen to offer to patients that is one that may be actually well tolerated by many patients to potentially avoid surgery altogether. And so there's certainly more to come on this, but we're now kind of in the infancy of recruiting patients for this trial that now, after sort of, I would say it's Dr. Hoffman since it's labor of love, but after a long sort of journey of getting it activated, is now finally up and running. And Stephanie highlighted our multidisciplinary clinic. Hard to believe that we're now almost at its fourth year anniversary. But we've been very fortunate, not even just restricted to urology and medical oncology, but to have participation from our diagnostic radiology colleagues, Dr. Farzad Sedagat, who has been involved in some of our UTUC MDC sessions, our pathologists, Dr. Andres uh, Matoso and also Dr. Ezra Baraban, nephrology colleagues, Dr. Derek Fine, genetics, also with kind of the Lynch syndrome hereditary predisposition that I mentioned. Sometimes UTUC is the first manifestation of that syndrome. Having a team of providers really, I would say, is critical to optimizing outcomes in patients with this unique disease and to minimize the potential for mismanagement. Now there's an official guideline endorsed by the American Urological Association that kind of provides guidance to clinicians on how to manage this complicated disease. So there's more and more resources that are coming out. This is the idea behind our multidisciplinary clinic is to really make a patient-centric opportunity that streamlines the ability for patients to receive care from multiple providers simultaneously, while also enhancing our clinical trial offerings, as well as our ability to collect samples from patients for our active biorepository efforts that really make it possible for us to do translational and basic research as well. And so this has really been almost like a crown jewel, I would say, of our UTUC program here and continues to grow. So I'd like to end on a positive note. I think I've sort of summarized where we have come thus far, and I've alluded to some of the kind of ongoing and exciting trials. But I do want to highlight some additional work that is ongoing, there are some buzzwords that you may hear about, and I wanted to when it comes to, for example, artificial intelligence or sequencing, next generation sequencing, and how they apply in the context of UTUC. One thing, this is actually a collaboration with some folks at Vanderbilt University, including the engineering team there. One thing I mentioned is that sometimes it can be very challenging to diagnose UTUC, and this is an example of how things look on the inside of the urinary tract, up in the kidney, using a ureteroscope. And these little areas that you see that are kind of sort of protruding out. They are basically like papillary fronds that are protruding out from the walls of the inner lining of the kidney are tumors. You can see this is actually the end of the video, but this is a great example of how a tumor actually looks. And it's all magnified here because we're using really small scopes and looking at it up close. But these can sometimes be on the scale of anywhere from microns to millimeters in size, and it limits our ability to even sample these tumors. And so there are ongoing efforts to enhance our visualization within the upper urinary tract using techniques like machine learning and artificial intelligence to better localize in a smart fashion, smartly localize tumors within the upper urinary tract to help reduce misdiagnoses, but then also potentially the opportunity to try and correlate the pathology and aggressiveness and the grade of these tumors, specifically from using these types of techniques, even just based on the appearance of these tumors alone. And I think if we can enhance our diagnostic capabilities in that regard, that would really enable us to more accurately and personally treat patients with UTUC. Another exciting venue is in the realm of biomarkers, and we have partnered with. So there's a lot of companies that have really kind of put out various panels for urothelial cancers, both in terms of circulating biomarkers in the blood as well as those in the urine. And because the urothelium is so closely integrated with the urine, when it comes to thinking about non-invasive biomarkers, it's almost a no-brainer to first look in the urine. We know from history that urinary cytology has often been kind of one of the classic biomarkers that we often will use for urothelial cancers, but it's limited by a relatively low sensitivity to pick up on these. And so in a partnership with a company called Convergent Genomics, we have been working on developing a pipeline using their proprietary DNA sequencing panel specific to urothelial cancers called UroAmp, whereby we have this proposition to simply collect urine from patients, have it undergo extraction and sequencing of DNA, and then yield information about the patient. And this is an effort that is being led largely by some of my former postdocs who are now back in Europe. On the top there, Dr. Maximilian Pilaf, on the bottom, Dr. Stefan Broneman. But essentially, we are working with them to retrospectively analyze many of our samples that were collected through our biorepository efforts, and found that, at least within our initial analysis within our cohort, UroAMP actually had quite favorable performance characteristics. It was conclusive in 100% of the 67 samples that we submitted in terms of diagnosing UTUC, and also demonstrated 100% sensitivity among patients that had quote unquote atypical cytology, which is often a non-specific finding. In comparison, cytology alone was conclusive in 67% of patients and demonstrated a sensitivity of 62%. Furthermore, we are also exploring whether there's the ability to disentangle bladder cancer from UTUC, as we're learning more and more about how these are molecularly disparate twins, although there may be shared, for example, mutations between the two. The frequencies at which we're finding these mutations are maybe different between the two. And so a urine test would be a great non-invasive way of being able to learn more about a patient, both in terms of diagnosis, but then also in terms of prognosis, and maybe even offer opportunities to predict therapeutic responses and guide treatment. There's another effort that is also currently ongoing, and that's understanding basically drivers of spread. So oftentimes when UTUC starts to spread from the kidney to other parts of the body, the lymph nodes are often a very common first stop before it may go elsewhere. And so this was a study where we sought to better characterize the molecular landscape by doing sequencing both within primary tumors as well as within tumors that metastasize to the lymph nodes, for the purposes of, number one, understanding the biology, a little bit more of what's driving these tumors to go to other places, but then also potentially seeing if there are ways to refine how we approach the management of these patients in terms of therapies, in terms of like lymph node dissection templates at the time of surgery, among other factors. And so this is an active work, and I do want to again give a special shout out to Joe Migliara, who really has made this work possible through his generous contributions, and we're very excited to see this work come to fruition, hopefully soon. So I do want to, of course, make sure there's adequate time for questions. But what I would sort of conclude with as a takeaway is number one, UTUC, albeit it's a rare cancer, it's important to differentiate it from bladder cancer, and also certainly definitely from kidney cancer. And even though we're translating a lot of treatment paradigms and our thought process of how bladder cancer arises and progresses to the space of UTUC, it really is its own disease entity. When managing patients with localized UTUC, grade and risk and stage really are the main factors that inform how we approach these patients. And ultimately, it involves a balance between preserving kidney function and making sure we're treating cancer effectively, but also parsimoniously when it's appropriate to do so. And as I had sort of highlighted earlier, it really is paramount to undertake a multidisciplinary, personalized approach, preferably at an experienced center, to ensure that patients are really maximizing their opportunity to treat this disease. So on that, again, I'd like to thank everybody who is here in attendance today, Stephanie, Dr. McConkey, and the GPCI for allowing me this platform to talk once again about UTUC. Happy to take any questions.
Well, that was just spectacular. So much progress in the past 10 years, I would say. And really since the last time you actually gave a talk on this, which was just like 2 years ago, so many more trials, so much more recognition of UTUC as its own entity. I'll ask Dr. McConkey to discuss his work with urine biomarkers. Wouldn't it be great to have a world where you just, gave a urine sample? All of us can do that pretty easily. And then you really can find out a lot in that sample versus more invasive procedures. But first and foremost, we have a question here from Judy, and she asks, what is the best follow-up test? CAT scan, ultrasound, or MRI after having, this is actually a bladder cancer question. What is the best follow-up test? CAT scan, ultrasound, MRI, or other after having a bladder removed? What would you
Yeah.
What would you suggest?
It's a great question, and I will say that because UTUC can sometimes arise in patients who have previously been treated for bladder cancer, just because they are often intimately associated with one another. It is important to make sure that you're undergoing um, imaging of the upper urinary tracts. In general, surveillance scans are important, so that includes most often, we tend to use CT scans that include the chest, abdomen, and pelvis in patients who have been previously treated with bladder cancers. If kidney function is a limiting factor, sometimes it's reasonable to substitute MRIs. I would say ultrasounds oftentimes give more limited information when it comes to properly restaging because you really want to make sure you're getting a good picture of the kidneys, the ureters, the lymph nodes, looking at the lungs to make sure that there are no nodules or other findings. But it is very much closely tied in with the surveillance of bladder cancer is the upper urinary tracts for sure.
You mentioned that the ureters themselves are small, they're hard to get to, they're hard to get samples of, and they're hard to see. So, in terms of like the assortment of scans, where can you see the ureters most, if that's even possible?
Yeah, so the in patients who can receive IV contrast, iodinated contrast, there's something called a CT urogram, and more specifically, what it is, it's a multi-phase CT scan, and there's what's called a delayed or an excretory phase, where the contrast gets excreted by the kidneys into the ureter and really illuminates the length of the ureter. And it's actually that phase within the CT scan that allows you to look for what are called filling defects that are basically look like darker spots that are not illuminated by the contrast. And that's simply because it's like a defect or basically it's a part that's not filled in because it's not hollow and it's an actual tumor. That's the most sensitive way of finding these tumors. And those can sometimes be quite subtle. Sometimes it really just manifests as non-specific thickening within the urinary tract. And so the way to really definitively then follow that up would be to do a direct visualization with a ureteroscopy.
So I'm going to ask a transportation question and about urinary markers, and that's for our beloved Dr. McConkie to answer. So, in a urine sample, is there a possibility, or does it exist right now, where you could detect possibly kidney cancer because it's different and it manifests differently and its DNA is different? And could there be in the same sample traces of UTUC and bladder? Do they all have different profiles in the urine is my question.
Yes. So, as Nirmish can probably elaborate on, kidney cancers don't seem to secrete tumor DNA as much as other cancers do.
Okay.
So, there have been efforts to detect them not through mutations, but through a process of modification to DNA called methylation. And
What
so,
does that mean, David? What is
it
method?
means it's what Bill Nelson and Vasan Yegna Subramanian have spent a lot of time studying. It's when DNA has methyl groups painted on it that cause either it to close, which is the kind of more familiar effect, or in some cases, depending on where it's placed, open. And so what we found, at least the preliminary data suggests, there was a group in Toronto that kind of pioneered the technique, and then groups at Dana-Farber and elsewhere have kind of validated this, is that if you find that methylated DNA in the blood, it may be a very sensitive way of detecting kidney cancer because you can tell the difference between the kidney cancers versus the normal kidney versus every other tissue in the body. So,
UTUC itself could have a unique urine profile.
correct. And we don't know if it's methylation or Convergent thinks it might have something to do with what we call open chromatin areas that are open to make messenger RNA. And through looking at the fingerprints that they get through the DNA and where it's cleaved and where it's degraded in the urine, they can see where maybe these open chromatin regions lay in the original tumor. And so they do seem to be able to distinguish bladder and kid and upper tract cancers just by the pattern of DNA fragmentation they see in the urine. Kind of like Victor Velkulisky is doing with other people too. So I think to summarize, it's all great, kind of an abstract, but it's not quite ready for clinical prime time yet. Whereas I think convergence test is pretty close. They've submitted for Medicare approval already
So,
for
Dr.
bladder.
Single, where would you use these urine tests? When would you, when you're following up with a patient or just initially diagnosing a patient, is the urine test when it's more perfected and presumably it'll be coming online at some point because there are a lot of hard workers going into it based on what David said. Um, will it be another tool to sort of define what the diagnosis is?
Yeah, so I think the answer is potentially all of the above. When it comes to biomarkers, we think about screening biomarkers in the asymptomatic patient. I think if it becomes cost effective, there may be not right now. There's not like a screening test for urothelial cancers across the general population, so that could be one potential opportunity. It's going to be probably limited by cost and sort of selected based on higher risk groups. But even for diagnosis, maybe, for example, a patient who has a finding on a CT scan that might be suggestive of the UTUC, rather than subjecting them to an anesthetic procedure with a ureteroscopy that's invasive, if we can diagnose them with a urine test alone, that may be enough. If you can learn more about how aggressive it is based on the urine test alone, that also can inform what to do next, and maybe even decide on what type of therapies, what we call a predictive biomarker. So screening, diagnosis, prognosis, and prediction, I think, are all the sort of buckets or categories of biomarkers that we're seeking to explore by looking at this.
Fantastic. I know we're up at the hour. Now I have a wild question for you. I've been dying to ask. We've noticed in the news at NYU and elsewhere that there have been some pig kidney transplants into humans, which have been blessedly successful, or somewhat, or it's new, but it's xenotransplant. Is that the word? So assuming that over time, this area field of study, transplanting animal organs into humans who need them, hope that doesn't disturb anybody. I see it as a positive. Do you see a day where ureters could be either 3D printed or grafted, or the transportation organ ureters could be rather than eliminate a kidney, could there be a ureter transplant alone someday? Do you see that coming?
Yeah. So believe it or not, in terms of like reconstructive urology, there are actually what we call interposition grafts that you can take even from the same patient and basically put it in as tubularize it as a ureter. So we don't often tend to do it for as much in the setting of cancer as we do for example, patients who have benign strictures or benign reasons why the ureter may stop working, where there's a long segment that needs to be repaired. But believe it or not, sometimes taking what's called the buccal mucosa, or basically a graft from the inner lining of the mouth, and actually refashioning it into a tube and using that actually mimics the tissue very well. So it's called
No
a
way.
buccal ureter. There's also something called ileal ureter, which is essentially taking just like you have an ileal conduit for patients who have bladder cancer, you can actually take a segment of the small bowel called the ileum and actually make it into a small little tube and connect one side to kind of the upper part where it meets the kidney, and then the other part kind of towards the bladder. There are limitations and risks. There are sometimes other complications that can arise from some of these approaches. I think that honestly, your question about like tissue engineering, 3D printing, how can those approaches potentially create, platforms or scaffolds that can then be implanted in humans? I think honestly that would be sort of a nice additional tool to have available in our arsenal to treat these patients when reconstruction can otherwise be challenging, or a patient who just has one kidney and we're trying to figure out how to preserve the kidney if they have kind of disease throughout the ureter but not within the kidney itself.
Well, that's the future, and you are the future. So thank you for this really exquisite talk. We've all learned a lot, and it is hopeful. So much has happened, and we're grateful to you and to David and the team of scientists behind the closed doors that we don't see, Dr. Hoffman Census, of course. And thank you for this really remarkable presentation. To all of our patients out there with UTUC, email us utuc@jhmi.edu if you have any questions or concerns or need just to contact us for any reason. We're there for you, and really appreciate Dr. Nirmish, Dr. Singla. We're glad UTUC found you. I think that's kind of how it happened, and we're glad that happened.
Sounds about right.
We have our next program will be kind of fascinating on April 15th from 4 to 5. It's with our beloved Dr. Noah Hahn, our medical oncologist. Well, a little bit off the beaten path, but something really provocative to think about. It's called comparative oncology and talking about, believe it or not, bladder cancer in dogs. It does happen, and what we can learn from that, and how the treatments and the research is very complementary and copacetic. So that will be bladder cancer in dogs with Dr. Noah Hahn. It's a thing, and it's been going on, and everyone's learned quite a lot, and it's fascinating. So I hope you all tune in again on April 15th. But Dr. Singla, thank you. And David, thank you for your time today. It
Oh,
was
thank
really
you for being such a
illuminating.
great host,
And
and Nirmish, as usual, great to hear.
keep
Thank you once
going
again.
and you are the future. And thank you for that. We really appreciate you. Thanks, everybody. Have a great night.
Bye,
Thank
everyone.
you so much. Take care.